Hello and welcome to our session today. Today we are continuing with our antihypertensive pharmacology, and the last session we were looking at diuretics and how diuretics are used to manage high blood pressure by inducing loss of water and other electrolytes like the sodium. Okay, and we were able to see how also it can also be used to manage even patients who are at risk of developing renal stones like the thiazide diuretics. So in this case we shall be looking into another concept, and this one will be involving the Raas system. We call it the Raas system. This is the Renin, Angiotensin, Aldosterone system. So in this one, we'll be looking at three major groups of drugs that are involved. But generally, we know whenever the blood pressure in our bodies falls, or when we have low sodium levels, even for that case, sympathetic nervous stimulation will normally lead to a response in the kidneys. So the kidneys, precisely the just glomerular apparatus, are going to secrete a hormone by the name renin. So this renin is going to convert the angiotensinogen, a protein that is normally produced by the liver, to be converted to angiotensin 1, which is a weak vasoconstrictor that later will be converted to angiotensin 2, which is a potent vasoconstrictor. So in that case, the angiotensin 2 is the one that is going to lead in consequently increase in blood pressure by stimulating the kidney to release aldosterone and also the pituitary gland to release ADH, and ADH is going to help in reabsorption of water, while aldosterone will lead to sodium retention, and the whole effect is that there will be increase in blood pressure. Equally, angiotensin 2 also helps work on the blood vessels so that it causes vasoconstriction. So the vasoconstriction, the reabsorption of water, and this increased sodium retention, all of these events are going to lead at increased blood pressure or a rise in blood pressure for that case. So pharmacologically, we could have the target points at renin, angiotensin 1, angiotensin 2, of course, angiotensin 1 and angiotensin 2. Angiotensin 1 is converted to angiotensin 2 by angiotensin converting enzymes, which is primarily produced by the lungs, but again, in certain pathologies, it could be also be produced in ectopic sites like the tumors. All right. So, and we could target this one using the ACE inhibitors, the angiotensin inhibitors. And equally, we could also work on the angiotensin 2 receptors by blocking it, where we call it the blockers, okay, angiotensin 2 receptor blockers or the Sartans. And lastly, the aldosterone receptor antagonist for that case. All right. Okay, so looking at renin, we have already said this is an enzyme that is normally produced by the glomerular apparatus in the kidney, and the work of it is to convert angiotensinogen produced by the liver into angiotensin 1. Okay, angiotensin 1, we have said it is a weak vasoconstrictor. Okay, so it has to be converted to a more potent one, which is angiotensin 2. All right, so and this one can be stimulated by either decrease in blood pressure, low sodium levels, or sympathetic nervous stimulation. From there, we have now the angiotensin 2. So this angiotensin 2 is an active precursor that has to be converted to angiotensin 2 by the angiotensin converting enzyme, and this enzyme is primarily produced in the lungs. Okay, we have said it can also be produced by especially tumors, right? Can also be able to produce this enzyme, right? So this angiotensin 1, it's a weak vasoconstrictor, so it has to be converted to angiotensin 2 by what we have referred to as angiotensin 2 angiotensin converting enzyme. So So angiotensin 2 is actually the strongest or the potent vasoconstrictor. It is the active form of this hormone. Okay, and you find that it has several physiological effects. One of it is vasoconstriction. So vasoconstriction, it leads to constriction of the vascular smooth muscles, and this one leads to eventual increase in afterload. And on the other hand, it also stimulates the cortex, that is the zona glomerulosa to be precise, and this one leads to secretion of aldosterone. Aldosterone is going to increase the reabsorption of the sodium retention, so that less sodium is retained. Equally, ADH is also released from the pituitary gland, and this one is going to cause retention of water. So in the end, we have increased preload. Okay, this is simply the amount of blood that fills ventricles during diastole. All right. So for us to really tackle this system, we could target the angiotensin 2, which is the potent vasoconstrictor. And one of the elements that we can use, or the pharmacological target points, is by using the angiotensin converting enzyme inhibitors, the ACE inhibitors. So this medication will be prescribed for patients with hypertension, congestive cardiac failure, and even those with diabetic nephropathy. So they represent, they do what? They suppress. Okay, and this could indicate the action in suppressing the BP. A dry cough is a common side effect of the ACE, so the patients have to be educated about this one. So this is the angiotensin 2, the one that we are preventing. We are preventing this process, okay, the conversion of angiotensin 1 to angiotensin 2. What are some of the examples of these angiotensin converting enzyme inhibitors? Well, we have a big number here. Okay, benazepril, captopril, enalapril, fosipril, lisinopril, moxipril, the prils. Okay, so we refer to them as the prils group, and one of the products that we're going to be looking at is the lisinopril. Okay, therapeutically, this is an antihypertensive, and pharmacologically, it's an ACE inhibitor, angiotensin converting enzyme inhibitor. We have different formulation available, including oral formulation, the tablets, right? And it's majorly indicated for hypertension. Okay, in terms of dosages, initially you could give 10 milligrams per oral daily for patients not taking a diuretic. Then you increase as needed to a maximum of 40 milligrams daily. For patient taking a diuretic, you have to start with a lower dose of about 5 milligrams per oral daily. Children who are younger than 6 years, who are 6 years and older, will initially be taking 0.07 milligrams per kg, and this should be up to 5 milligrams, okay, per oral once daily. Then you can increase this dosage based on patient response and tolerance. So maximum dose should be 0.61 milligrams. So you don't need to exceed 40 milligrams, okay, to avoid unwanted side effect. Don't use in children whom the creatinine clearance is less than 30 mils per minute. You have to adjust the dose in patients who are having the creatinine clearance of between 10 to 30. So you give 5 milligrams per oral. If the clearance is less than 10, you can give 2.5 per oral daily. Then you may titrate this dose up to 40 per day. Adjunct therapy, especially with diuretics and cardiac glycosides for heart failure patients, for these adults you can give them 5 milligrams per oral daily. Then you can increase the dose to a maximum of 40. You have to continue to adjust the dosage. If the sodium level is less than 130, the serum creatinine level is greater than 3 milligrams, or the creatinine clearance is less than 30, you start the treatment at 2.5 milligrams daily, right? Okay, so orally, this drug, lisinopril, you give these drugs without regard to food. The oral solution is bioequivalent to lisinopril tablets. So you have to store the oral solution at room temperature in a tightly closed container. You protect from freezing and excessive heat, and if the tablets are made into a suspension by a pharmacist, you can store it at or below 25 degrees Celsius for up to 4 weeks, and you have to shake before use. The action or the mechanism of action we have said. Okay, so this is the site here, guy. It causes decreased production of angiotensin 2 and suppression of the Raas system in the long run. Okay, the route per oral, you find the onset is usually within 1 hour, peak of 1 hour, and duration of 24 hours, but the half-life of 12 hours. One of the most threatening side effects, it is the angioedema, and you have to stop the drug. Okay, you have to stop the drug because of this. Okay, this is a life-threatening side effect. The others can be listed in terms of interaction. Drug-drug interaction, we have the AC inhibitors and angiotensin receptor blockers. If you have dual therapy, they may increase the risk of renal impairment, hypotension, hyperkalemia. Okay, so concomitant use of aldosterone is contraindicated in patients with diabetes. You have to avoid use of this. Okay, use together. Allopurinol may increase hypersensitivity reaction, so you have to use together cautiously, while azathioprine may increase the risk of anemia, leukopenia, so you have to monitor hematological studies if used together. Then you have the cyclogenase 2 inhibitors, indomethacin, NSAIDs. This one may increase the risk of renal dysfunction, so you may reduce these drugs also they may reduce the hypotensive effect of lisinopril, so you have to adjust as needed. For the diuretics and the thiazides, this one they may increase excessive hypertension when used together with the lisinopril, so you have to monitor the BP closely. While the use of insulin and oral anti-diabetics for diabetic patients, the lisinopril may cause hypoglycemia, especially at the start of the lisinopril therapy. So you have to monitor the glucose level. What about the lithium? I find the lisinopril may cause lithium toxicity, so you have to keep on monitoring the lithium levels. All right. These inhibitors may increase the risk of angioedema, and angioedema, we have said, it's a risk factor, it's a life-threatening situation. The drug has to be stopped. All right. What about the use in potassium-sparing diuretics and potassium supplement? This one may cause hypokalemia. You have to keep on monitoring the lab values. Okay. For the herbs, lisinopril may increase antihypertensive effects when used together with the herb. So you have to discourage the use. You have to discourage the patient from using the lisinopril and the herbs. Right. For the food, potassium-containing salty substitutes. This may increase hyperkalemia, so you have to keep on monitoring. Generally, lisinopril may increase the blood urea nitrogen, the creatinine, potassium, bilirubin levels, and the LFT values, and they may decrease the HB and the hematocrit levels. Lisinopril is contraindicated in patients who are hypersensitive to AC inhibitors and those with a history of angioedema, which is related to previous treatment with an AC inhibitor or any other antibiotic associated with this one. So you have to use cautiously in patients with impaired renal function and adjust accordingly. Use cautiously in patients who with risk for hyperkalemia or hypertension, in those with aortic stenosis and hypertrophic cardiomyopathy. The safety and effectiveness of lisinopril on BP control in children younger than 6 or children with GFR less than 30 hasn't been established. So angioedema also can be fatal and may occur at any time during treatment, including the first time dose, or it may involve the head and neck. Okay, potentially this compromises the airway and the intestine, presenting abdominal pain. So patients who are black and patients with idiopathic or hereditary angioedema may be at increased risk. So in black patients, you have to really be keen because there is a high likelihood that we might have angioedema, right? Patient concurrently receiving mammalian target for ripamycin inhibitor therapy also may be at increased risk for that case. So this, thank God, this drug is dialysable, and the most overdose side effect is hypotension. In terms of pregnancy, lactation, and reproduction, it is a boxed warning, so the drug acts directly on the Raas and can cause injury and death to the developing fetus. So when pregnancy is detected, you have to stop this drug as soon as possible. For the milk, it isn't known if the drug appears in the human milk, so patients should discontinue breastfeeding or discontinue the drug. Okay. What are some of the nursing responsibility for to a patient who is using lisinopril? So although SE inhibitors reduce BP in all races, BP reduction is less in patients who are black and who are taking an SE inhibitor alone. So patients who are black should take the drug with thiazide for more favorable response. So you have to monitor the BP frequently. If the drug doesn't adequately control the BP, diuretics may be added, and you have to monitor the white blood cells counts before the therapy every 2 weeks for the first 3 months of the therapy and periodically thereafter. Then you monitor the serum potassium level periodically. The normal range should be between 3.5 to 5.0 mil equivalents. SE inhibitors have been associated with hepatic failure, so you monitor the patient for jaundice, significantly increased liver enzyme levels. Look alike, sound alike drug, don't confuse lisinopril with fosinopril, right? Don't confuse Zetril with Zoctres, right? So that's also some of the nursing responsibility that you have to know. Okay. The patient teaching, although we have although rarely, we normally have the facial and throat swelling, including swelling of the larynx, or intestinal swelling may occur, especially after the first dose. So you have to advise the patient to report any abdominal pain, or breathing problems, or swelling of the face, eyes, lips, or tongue. And you tell the patient that lightheadedness can occur, especially during the first days of the therapy, to rise slowly and minimize this effect and to report the symptoms to the physician. If fainting occurs, you advise the patient to stop the drug and call the physician immediately. And if unpleasant adverse reactions occur, you tell the patient to stop the drug suddenly but to notify the prescriber immediately. Okay. Always advise the patient to report the signs and symptoms of infection such as the fever or the sore throat, because this could be touching on the airway. You have to tell the patient of childbearing potential to notify the physician if pregnancy, because pregnancy the drug has to be stopped, right? The drug will need to be stopped. Advise the patient to report any signs and symptoms of hyperkalemia, like muscle twitching, weakness, nausea, abnormal heart rhythm. All right, of course in the ECG they'll be having some T peaked waves, okay, peaked T waves. You have to instruct the patient not to use salt alternatives that contain potassium without consulting the physician. Then a dry cough, which is non-productive, may develop during the therapy due to accumulation of bradykinin. So I hope you can see here, guys, when you have an ECE, it's going to block the conversion of angiotensin 1 and angiotensin 2, and this can also, we can also see this one. Also, it is going to block the conversion of bradykinin, which is produced into inactive product. So when it remains there accumulating, it's the one that will lead to this non-productive cough for that case. Okay, so guys, so that was the first group under the Raas system, okay, the angiotensin converting enzyme inhibitors. So guys, if patients are cannot tolerate these ACE inhibitors, the alternative that is there is the angiotensin receptor blockers. We normally refer to them as the Sartans. Okay, these ones, they work by blocking the binding of angiotensin 2 to its receptors, and therefore this will prevent the vasoconstrictive and aldosterone stimulating effects for that case. So this one will have been blocked for that case. Examples includes the losartan, valsartan, irbesartan, candesartan, olmesartan. So they are referred to as the Sartans, okay, angiotensin receptor blockers, all right, for that case. The last group, guys, is aldosterone antagonists. Okay, remember aldosterone. Normally, we have angiotensin 2. The angiotensin 2 Angiotensin 2 will trigger the adrenal glands to release aldosterone, and also stimulate the pituitary gland to release the ADH. Okay, so we say the ADH will cause reabsorption of water, while the aldosterone will cause increased retention of sodium. So together, aldosterone and ADH, they will cause the kidneys to retain more sodium and more water. Okay, and the aldosterone will cause the kidneys to release or secrete potassium through urine. All right. Okay. Fine. So when it comes to aldosterone antagonists, so these are drugs that will block the action of aldosterone at its receptors, okay, in the kidney. So therefore, they will reduce the sodium reduce sodium reabsorption and do the opposite now, promote potassium retention. Okay, so these drugs are also referred to as potassium sparing and diuretics, right? Potassium sparing diuretics, and we already looked at them when we were looking at the 5 types of diuretics. Okay, guys, a link will be popping up on the 5 different classes of diuretics, of which potassium sparing diuretics, aldosterone antagonist being one of the subgroup under the potassium sparing antibiotics. So we have the spironolactone as an example, which is the oldest aldosterone antagonist, and it competitively inhibits aldosterone receptors in the distal tubule and in the collecting tubule, and this thereby reduces sodium reabsorption and potassium excretions. Okay, so it is used in treatment of conditions like hypertension, heart failure, and edema. So this you have to know, the general knowledge is that about 2 to 5% of filtered sodium is normally reabsorbed in the collecting tubule. So this group of drugs is able to block this portion. Okay, so in the long run, aldosterone antagonists normally lead to loss of sodium and water, retention of potassium, leading or risking hyperkalemia, and lastly we could have some risk for acidosis, okay, because when you have the reduced sodium influx, it decreases the electrogenic exchange for sodium now for the potassium and sodium, and this can cause hyperkalemia and acidosis because potassium and potassium and hydrogen are retained, and when you have more hydrogens, guys, you result into what? Into an acidic environment. Guys, a link will be popping up on the different types of acid base balances. Thank you, guys. That marks the end of the presentation on the Raas system. We have looked at angiotensin converting enzyme inhibitors. Then we went ahead and looked at angiotensin 2 receptor blockers, or the Sartans, and lastly aldosterone receptor antagonists. Thank you so much.